Training standards for coronary angioplasty. Accredited fellowship program. There have been advances in interventional procedures and there is a high and durable success rate despite increasingly complex procedures. So 125 procedures must be performed, including 75 performed with trainee as a primary operator. So what are the recommendations for clinical competence in percutaneous transluminal coronary angiography? Total number of cases 125, 75 cases as primary operator and 50 to 75 practicing number of cases per year to maintain competency. Femoral artery puncture technique. Common femoral artery is the area which should be punctured. It is located above the femoral artery bifurcation and below the internal epigastric artery. The arrowed area. Upper red line indicates the lower border of internal epigastric artery and lower red line indicates the bifurcation of common femoral artery. The yellow dotted line is showing the femoral head. Correct needle entry position is below inguinal ligament and above femoral artery bifurcation. Key points for femoral arterial access for interventional procedures. Always consider radial access first because there are lesser bleeding complications. In obese patients, place a hemostat or marker over the planned puncture site and fluoroscopically visualize the femoral head. Consider using a Doppler needle or other ultrasound guidance for deep or difficult femoral punctures. If anticipating need for large bore equipment, for example rotablator or two stents for treating a bifurcation, a more than or equal to 7 French arterial sheaths should be used. So today we will discuss radial artery access for percutaneous intervention. Advantages over femoral access are there are no or less bleeding complications. There is easy accessibility as there is collateral flow to the hand through the ulnar artery and in the presence of normal Allen test there is safety and patient is having early mobility after the procedure. As shown in the graph, the bleeding complications with yellow bars radial PCI and vascular complications are also less with radial PCI in the yellow bars. In both below and above 75-year-old patients. Gender-wise comparison, bleeding complications are less with radial PCI as well as vascular complications. And when we compare with the presenting condition, stable angina, non-ST or STE elevation MI, radial PCI is highly safe, especially in ST elevation MI patient with regards to vascular complications. Anatomy for radial axis for angiography. Aortic arch gives off the great vessels. Innominate artery on the right, common carotid and subclavian arteries on the left. Axillary artery on the right gives to right brachial and right radial artery. On the lateral margin of first rib, there is transition from subclavian to axillary. On inferior border of teres major, axillary continues as brachial, and brachial artery bifurcates in most patients into radial and ulnar arteries below the elbow. Here is the diagram and the angiographic image of the brachial artery dividing into radial and ulnar arteries. Some patients will have anatomic variants, and most common variant is the radial artery originating higher than the elbow. The various anatomic variants have been shown in the figure. In cubital crossover from A to F, G showing right radial artery angiogram showing conventional anatomy of the radial artery, H showing the right radial artery anastomosing to brachial artery in the cubital fossa. In I and J angiographic images, there is indication of radial artery loops. In K angiographic image, there is small radial artery continuing superiorly as brachioradialis after a small anastomosis to brachial artery in cubital fossa, indicated with arrowhead. And in the L angiographic image, the radial artery continues superiorly as brachioradialis artery without a discernible cubital crossover to the brachial artery. The radial artery will continue along the lateral aspect of the forearm into the wrist, where it passes over the scaphoid and trapezium bone and divides into two deep and superficial palmar arches. So these are the deep and superficial palmar arches on angiography. Caution should be to avoid cannulation of radial artery too distally. The figures showing optimal position of the hand and the cannulation catheter and as well as the right area to go for while cannulating the radial artery. So today we will discuss the Allen test, the modified Allen test, and grading of waveforms in Allen test with plethysmography. Importance of Allen test is that it's a strong recommendation for the radial procedure. It assesses the adequacy of the palmar arch and the ulnar flow. Practically, the patient makes a fist, pushing blood from the hand. Radial and ulnar arteries are compressed and simultaneously occluded. When the hand is opened, the palm appears blanched. Release of ulnar artery should result in return of pink hand color within 8 to 10 seconds. So normally, as shown in the figure, the palm is pink, fist is made, and the radial and ulnar arteries are compressed. The hand is open and blanched after compression of both ulnar and radial arteries. The palm is pink after release of ulnar artery with radial artery occluded. So, is there anything better than Allen test? More objective measurement of satisfactory ulnar flow can be documented by pulse oximetry. Using the oximeter, the pulse wave is displayed with both arteries open. So here, before radial or ulnar artery compression, pulse oximeter waveform is shown and it is normal. Waveform is flat when both radial and ulnar arteries are compressed. Pulse waveform is normal when only ulnar is released, radial is still compressed. It is called type A response. Type B response is blunted waveform and type C is flattened wave. So there are four grades of waveform. Barbeau classification. Type A, no change in pulse wave. Type B, damping a waveform that return to normal within 2 minutes. Type C is loss of phasic pulse waveform that return within 2 minutes. And type D is loss of pulse waveform without recovery within 2 minutes. So here is type A response. The type B response is shown, type C and type D responses of radial artery compression. The start in the A and after 2 minutes in the A and similarly in the B, C and D. The persistent damping of plethysmographic curve and a decrease of the blood oxygen saturation indicate inadequate ulnar collateral circulation. Barbier and colleagues compared such a method with Allen test in 1010 consecutive patients. The study showed that 6.3% patients would be excluded based on the Allen test, but only 1.5% had an abnormal plethysmographic test. Although use of Allen test and grading of the results for patient selection safety concerns may not be well supported by data, in some areas this may be considered standard of community practice. In such cases, radial artery cannulation is recommended with type A and B results, can be considered with type C results, and contraindicated with type D results. A reverse Allen test is done by occluding the ulnar artery, and it is recommended for patients with a history of previously accessed radial artery for arterial blood gases or radial seizures. And that is the presentation for today. Thank you very much for listening.